Hello, I'm Larry Levitt from KFF. Welcome to the latest episode of the Health Wonk Shop. Roughly once a month, we dive into timely and complex health policy topics with experts from a variety of perspectives. Over the last 2.5 years, the US has taken unprecedented steps to respond to the COVID pandemic. There have been trillions of dollars in funding and, in effect, universal coverage for vaccines, testing, and treatment. But that is all starting to come to an end. Though the Biden administration continues to request additional funding, Congress has yet to act, and the federal government is running out of COVID response money. And we could soon see an end to the public health emergency declaration, which has brought an array of regulatory flexibilities and protections. These changes will trigger a transition to a more commercialized approach to COVID, which is, after all, how we approach all other health conditions. We're joined today by an impressive group of experts to tease out what this will mean. Dawn O'Connell is Assistant Secretary for Preparedness and Response in HHS. Rena Conti is an Associate Professor in the Business School at Boston University and an expert in drug markets. And Jen Cates is a Senior Vice President at KFF and leads our Global Health Program. If you have questions, submit them at any time through the Q&A button. We'll get to them, as many of them as we can. Also note that this session is being recorded and an archived version should be available later today. Dawn O'Connell, let me start with you. Could you give an overview of the federal government's current transition plans if COVID funding is exhausted and the public health emergency ends?
Well, Larry, first of all, let me thank you for having me. It's a real pleasure to be able to join you all today for this conversation. This is one of the most important pieces of work we're focused on right now in the COVID response at HHS. And we always knew we would not be in this business forever. So Larry, you did mention, the funding issues and the PHE issues, but we were going to transition at some point regardless, because it was important while supplies were limited, while we were in this national emergency, that we were able to provide access to all of the countermeasures to every American that needed it. And as we begin to have more accessibility, more supply, not in a supply constrained environment, moving it into the commercial market, Larry, to your point, which is where the vast majority of other healthcare care is provided, was always part of our plan and something that we needed to do. But the process is complex, and so it's really important that we've started this now. So just to give a little bit of a sense of where we are, each of our products is going to move at a different time, depending on what their regulatory status is. Medicare and Medicaid cover things differently if they're approved versus whether they're under EUA, emergency use authorization. And so we're having to account for that. For example, in the antiviral space, Medicare Part D doesn't cover something under an emergency use authorization. And so when will our antivirals move into an approved status? These are all parts of the timeline that we're currently trying to manage. In addition, we're working very closely with all of the manufacturers who've been terrific partners throughout this process. Thank goodness they were willing to step up, put other commercial work aside and take on the government's request to have these COVID countermeasures available. But we need to make sure that they have enough supply on hand to be able to go commercial all across the country at the same time. So much of the supplies have gone to the US government, and we're currently continuing to make them available. But there's going to be a point where our supplies run low and their supplies need to ramp up in order to take on this work. So what that timing is for them on their manufacturing lines is also another important component that we're continuing to look at. So regardless to say this is complex, each of these are going to move differently. Eli Lilly, the manufacturer of the currently available BEV, the only monoclonal that we have that works against Omicron, went commercial in mid-August. So we've learned some lessons and give a lot of credit to Eli Lilly for stepping up and being able to do that. And we've been working with them to learn some lessons about what that was like, to be able to continue to provide accessibility as they think about how they will continue to provide this product to the uninsured moving forward. So we're learning as we go and very active and collaborative conversations. And so this is just going to be a process which I'm looking forward to talking through. I won't have all the answers today because it is complex, and we've, at the beginning of this, but lots to think about, and really looking forward to getting some feedback as we have this conversation. And Larry, not to keep going, but you mentioned our request for COVID funding. So regardless of whether we were going to get COVID funding, we were going to eventually have to make this transition at some point. The part of the COVID request makes this a little less bumpy. I mentioned that point at which we run out of supply, a manufacturer needs to ramp up supply. We can calibrate that easier if we're continuing to be able to purchase these while the manufacturer continues to ramp up. We might not be in a position to be able to do that if we don't have the funds to continue to procure to meet that equilibrium. But regardless, we're doing everything we can to manage this so it's as less bumpy as possible for the American public, which so deserves to have these countermeasures available. Larry, I hope that answers your question. Again, very pleased to be here. Thanks for the good conversation.
No, very helpful. So Dawn, you mentioned that the administration is still seeking funding to kind of ease the transition to commercialization. Could you just describe really briefly kind of what the administration is looking for in terms of total funding and how that funding would be used kind of during that transition?
Sure. There was a request that went in September that accounted both for the COVID response and the monkeypox response. There's $18.4 billion that was requested for the COVID response. Of that, a large portion of it is for next generation vaccines and therapeutics, and that's a critical request for us. You know, we continue to be in this cycle of new variants coming on, vaccines needing to be updated. What we really need and hope we can move towards in the coming months are new, the next generation of vaccines, the next generation of therapies, those that do not evade various variants, but are actually able to protect against all variants that we see coming. And that would get us out of sort of this boom bust cycle of, you know, surge in cases and needing to go to the next updated vaccine or needing to continue to have a boost. In therapies, we've lost many of our monoclonals because of the various variants that have come on. As I mentioned, we only have the Eli Lilly one available right now. It would be wonderful if we had additional therapeutics that were resistant to that were not resistant to the variants, but worked against whatever was coming next. So all of that's really important for our response. We also asked for an additional bucket of funds in order to be able to procure, as I mentioned, to make sure that supply and demand were able to meet. Also, some of that funding would go to an uninsured program just to make sure that we continue to provide accessibility to all Americans, those that have insurance and those that don't have insurance. And commercialization, of course, speaks to those that do, and not everybody does. And so we want to continue to have access to those that need them. So those are among the things that we're looking for by asking for additional funding.
Very helpful, thanks. So Jen, let me turn to you. Dawn mentioned people who are uninsured. You know, as we do transition to commercialization, we're going to lose this idea of kind of universal coverage for vaccines, testing, and treatment. So starting with vaccines, talk a little bit about what will happen when the government stops purchasing doses, when the public health emergency ends. How will coverage and out-of-pocket costs change?
Thanks. Yeah, we looked at this question very carefully and released a document yesterday that tried to address it. And what we discovered in doing this, it's a very complex web, as Dawn mentioned. So there's the public health emergency aspect, there's the supply that's been purchased aspect, and then there's Medicaid, Medicare, private insurance, and the uninsured. And for each of those categories, there's a slightly different answer. But the uninsured, I mean, a couple of big messages come across from our look at this. One is who you have insurance from, and or if you don't, really matters. So the uninsured stand to lose the most, and I'll say some more about that. The other thing that's different is it matters if you're talking about vaccines, treatments, or tests. So in a sense, if I had to pick, you know, one thing that I needed access to once all of this process was done, I'd say vaccines, because we, in addition to having sort of a universal coverage environment during this public health crisis, once we move to a commercial market, other than the uninsured, and I'll get to that in a minute, everyone with public and private insurance should still have free access to vaccines without cost sharing, which is an incredible thing to be able to have. There is a supply issue, as Dawn mentioned, if manufacturers aren't making enough, but at least from a coverage perspective, vaccines should be mostly taken care of. The big issue there is for the uninsured. If you're a kid who's uninsured, you can still get vaccines. You can still get the any updated COVID vaccine, any booster that you might need through a program that the government has called the Vaccines for Children program. If you're an uninsured adult, you're kind of out of luck. There is a program, but it's funded every year. It's not at all funded for COVID, you know, adding COVID to the sort of the list of vaccines there. And so you're not guaranteed getting that access once we move to this new market. Just in brief, so we can, because a lot to cover, It's a little bit different for treatment and tests. Under the sort of current public health emergency and federal supply situation, most people have been able, well, certainly could get free supply when it was purchased by the government. And what is going to happen, though, once that ends, is a lot of people are going to face cost sharing. If you have public and private insurance, you'll still get them, but for them, they're likely to be cost sharing in your future if you haven't already encountered it yet. And in some cases, you might not even get coverage for it, even if you have insurance. So there's some insurers that probably won't cover it, don't have to. And then lastly, same on tests. And lastly, I'll just say the uninsured, whereas I mentioned they'll still have some access to vaccines, they'll have no guaranteed access at all to tests or treatment in a new environment without federal purchasing and protection. And maybe Don will want to mention this, but the federal government the Biden administration has put forth a request to Congress to create a new program for uninsured adults to allow them to have access to immunizations for COVID and everything else that you or I might get through our insurers, but they can't currently.
As we discussed earlier, this is a big change for COVID vaccinations, tests, and treatments, but it is like we handle everything else in our healthcare system, with differences by insurance status and certainly less access for people who are uninsured. Rena, let me bring you in. So, an aspect of this commercialization and shifting from advanced purchase of vaccines and treatments is that negotiation over price will now happen commercially between insurers and pharmacy benefit managers and manufacturers. I won't ask you to look into your crystal ball and predict what the price will be, but give us a sense of what direction you would expect the price to move in for vaccines and treatments.
Sure. So there are 4 different technologies that are being used currently for COVID and are expected to be used in the near future. The first is screening. The cost of screening for some people who are uninsured or who are underinsured clearly has been onerous, on the order of somewhere between $800 to $1,200. But hopefully some of the measures that we've already talked about, especially for the folks who are uninsured, will continue to ensure access, even if those prices stay the same. They still are not affordable for all. Then there are the treatments, the drugs that are used in the inpatient setting, some of which are used in the outpatient setting to manage symptoms that are generic. They existed before the pandemic, and now they've been repurposed to use for management of treatment. Many of those drugs, even during the pandemic, did not see very significant price increases. That is a credit to the industry that they did not pursue prices even when demand clearly went up for their products. And again, for those products, we don't anticipate that a change in coverage or federal support should alter the economics there. Prices should stay stable. Then there are the new therapies that are COVID approved or authorized. And that's where I think the risk of prices rising when federal support is reduced are most salient. There are 2 therapeutics categories, the ones that exist that are authorized now. Here we have to kind of wait to see what happens with FDA authorization and ultimately approval. If and when these products are approved by the FDA, then they will go into the normal bucket of coverage by insurers. And we expect that insurers will use exactly the same techniques that they do now to manage costs, which are related to negotiation. Some of the PBMs and insurers are covering more than 1 million lives. They have certainly a lot of bargaining power over these companies. And again, we anticipate that we'll see price concessions from them. There are other therapies for which there's no competition, or where they have yet to be come to market, where we anticipate the prices will rise.
Dawn, let me come back to you. So, people who are uninsured are likely to face the biggest challenges as we move towards commercialization. And in fact, we've already seen that with the program for uninsured people running out of money and no funding no longer being available to reimburse providers. What are some of the plans you all have considered to fill in that gap for people who are uninsured?
So of course, equity and access to all these countermeasures has been a cornerstone of, the work that we've done. It's been critical from the president to the secretary that this be a focus of the work that we do. So as you can imagine, as we talk about the complexities of the work ahead of us to get all of this right, focusing on those that don't have insurance, that are underinsured, has been a critical part of that. And again, one of the challenging pieces in the complexity is making sure that we continue to provide access. So we're looking at a few things, and Jen mentioned one of them. In the FY23 budget proposal, we put something forward, a vaccine for adults program proposal, very similar to, as Jen described, the vaccine for children's program that CDC currently runs. We would launch a vaccine for adults program, which would cover these vaccines, which we agree would, are among the more critical of the countermeasures that we need to continue to provide to everybody who wants them. So that's one piece. We also have a wonderful federally qualified health center program that HRSA runs, and that provides care on a sliding scale. So it's not always for free, but it does provide care, and it takes into account the amount of money that you have and your ability to pay. And it does provide access to vaccines, to therapies, to tests, to all of these things. And we'll continue to figure out through our annual budget, if we're not to get any more COVID-specific funding, how to ensure that those health centers continue and are able to provide to all Americans that need them. And then we're going to work, of course, with the industry partners. They've, again, from the beginning, have been critical in putting aside other work to help us develop and manufacture and make available these countermeasures. Many of them run various programs to provide access, and it's important to us that we look at those programs, figure out how we might encourage them to make them available and generous, in this once in a lifetime pandemic that we're all responding to. So we're trying to pull a few levers all at once. The lack of funding does create a little bit of a challenge here, but this continues to be one of the biggest priorities of our work. And so we are looking at that, and of course, and pleased by this conversation to hear any additional thoughts folks might have that we can bring to the table.
So just a reminder that you can ask questions at any time, and we'll shortly turn to questions from the audience. Rena, let me come back to you. So the government has negotiated the price of these vaccines and treatments, but another important aspect of the government purchase has been a guaranteed pre-purchase. So essentially guaranteeing a market for tests, for treatments, for vaccines. As we move to commercialization, what are the things we need to think about in terms of making sure that these countermeasures are available in a timely way and in adequate supply?
Yeah, thank you so much for the question. I think the key economic issue here is that in the absence of federal guarantee of either purchase and coverage and potentially underwriting of manufacturing at risk, new vaccines and new therapeutics to address COVID and frankly other medical countermeasures will remain underinvested in. And indeed, I think that's actually one of the biggest risks here, and one I think that the administration is very keen on trying to address. In that, innovators really do need to understand that there is a market for their products, and that when even if we see this pandemic kind of receding into the background for ourselves, that doesn't mean that there isn't worldwide demand for both preventives and also therapeutics. But also there will be another pandemic. There will be other use cases for these therapeutics. And so making sure that there's a robust investment by the private sector in such medical countermeasures is absolutely critical to moving forward.
Larry, can I jump in on that and
Yeah,
just say something, which I think if we think back just a year, we actually all lived through this a little bit. So prior to the Biden administration purchasing for every American free tests, at-home tests, and creating the new policy, 8 free tests per month if you have insurance, there was a testing shortage. Well, why was that? Well, we were out of that surge, and vaccines were, being rolled out, and we all felt maybe we're in a different place. And the testing manufacturers for the tests that were already authorized didn't see a market. They didn't see the demand that they felt that they needed to see, or the guarantee. So why would they go about making those tests? And they didn't. And then we had Delta and some other factors, and everyone was scrambling and couldn't find tests for quite a while. All of us, I'm sure, included. And so that is the dynamic we're talking about that could play out again and again, even if coverage protections are there, even if those didn't go away. So the advanced purchasing or the guarantee market is a really key part of this.
If I could just add, I couldn't agree more. And I think we've seen over and over again kind of boom and busts where government and or other payers get interested in bringing new antibiotics to market, for example, or a Zika vaccine to market, et cetera. And then that sustained commitment to making sure that the innovators will continue to innovate and also keep the capacity warm to make these things if and when we need them kind of wanders away, and then the companies move on. And so this is a very unique situation where, in some sense, what we want to do is tell the innovators, make it, but we hope we never ever use it. Right? And so we need very specific and intentional incentives in place to ensure that there's sustained effort by the public sector signaling to the private sector, and the private sector continuing to invest to continue to make sure that we are safe.
Larry, can I put one quick plug in to what Rena just said? So BARDA, which sits in the organization that I lead, does exactly, Rena, what you've described for all the threats that we're looking at. It creates that government-created incentive to be able to bring some of the smaller biotech companies forward to innovate against some of our more challenging threats across the biological, chemical, radiological landscape that we're currently facing. So BARDA was part of Operation Warp Speed at the very beginning, which launched and got these vaccines and therapies moving as quickly as they did. It would be interesting as we continue to think about annual budgets, how we can make sure that BARDA gets to play a role, Rena, as you described, and in continuing to do the innovation in the COVID space and keep companies invested in moving while it looks and returns to its regular portfolio of those chemical, radiological, biological, and other threats. So there probably is a play there for us to consider moving forward and keeping BARDA engaged.
Dawn, go ahead, Rena, sorry.
I totally agree. And I think that part of what I was working on during COVID was just continual love letters to BARDA. So just to make sure that people appreciate the role that BARDA played, they were both identifying companies that had standing capacity to make existing products that needed to be on the ground in order to help people in the emergency. They were also identifying innovators who are willing to innovate in very time-constrained and otherwise constrained situation. And incredibly, they were investing in manufacturing at risk for products that hadn't even been authorized or approved, not just for the US population, but also, frankly, for the worldwide benefit. I have done some work in this area. It is very rare to have other governmental or non-governmental agencies who could actually span the scope of that. And really, probably the only other entity that looks like that is CEPI, which is an international organization. And even they had to change their charter to help support manufacturing at risk. We cannot let go of this. We are the international leaders in this. It's what kept us safe and got our economy back in order, us back to work and back engaged. And my view is that this is a all of government solution. So we need BARDA with sustained mandated funds that they can continue to do what they're doing in their purview. And we need other government agencies also focused on thinking about the delivery piece and thinking about the approval piece to make sure that when and if these products come to market, they have a sustained, identified agency who's expert in handling them and getting them through their approval process.
John, let me come back to you. So I know the administration is still requesting additional money, both in supplemental requests and the annual appropriations. But if that funding does not come through, or it comes through at lower levels than hoped for, what are some of the other things the government can do short of money or guaranteed advance purchases to kind of manage the pipeline and to guarantee that there is continuing access to both existing vaccines and treatments and new innovations?
Absolutely. So as we move away from the potential of this COVID supplemental funding, funding dedicated just to COVID, we're looking in ASPR, the organization that I run, we're looking at they're always a year ahead. I think you all probably know that in the fiscal year process. So we've been building out an FY24 budget and what should go in that. And one of the key priorities that I've built into that is the enduring COVID response. COVID's going to be with us as much as we wish it wasn't. We're going to have the enduring, effects. We're going to have the need to continue to bridge some gaps, figure out, as Rena talked about, how we continue to move. If we're not able to get a separate supplemental for next generation vaccines and therapeutics, can I get funding within BARDA to be able to push against those things? So we are thinking about how annual funds begin to take on some of this work that we've been so reliant on, the COVID supplemental funds, but we also shouldn't underestimate the influence of the federal government. Just having the imprimatur of the government at the table with, with these companies, with our partners, including the pharmacies and the distributors, the warehouses, all of these who have been willing to come forward to put other work aside to engage in this work with us, and not always at to financial gain. I think is critical. In this once in a lifetime pandemic, people have wanted to step up. They've wanted to serve. They've wanted to work together, and we can continue to harness that, Larry. That's not as satisfying, certainly, as going in and buying as many, therapies and vaccines as we need and doing it quickly. But we do continue to have the ability to influence, to persuade, to engage, and to work together. And we were pushing on all of those levers, as you can imagine.
Great. Well, we have a lot of questions from the audience that I want to make sure I get to. And one is very simple, which is, what is BARDA? And Tom, maybe I could ask you to briefly describe what BARDA is and what it does.
So BARDA is one of the premier government research institutions, and it sits in the organization in ASPR, which just became an operating division. So we just switched names. It is the Administration for Strategic Preparedness and Response, and BARDA is a Biomedical Advanced Research and Development Authority. And BARDA's role is interesting, and I don't think a lot of people understand it, but it has this catbird seat. It gets to sit and pull these promising candidates through the pipeline into advanced research development approval, as Rena mentioned. So let's take, for example, within the HHS construct, we've got NIH, which does early research and development. So they take things through phase 1. They figure out what the problems are, they're identifying what might work, and they're beginning to test those theories. And then if they are successful through phase 1, they come and tap us. And they say, okay, BARDA, we've got something that's promising against a threat or against a disease or against because that's our remit, is to look at the current threat landscape and figure out medical countermeasures to protect America against those. So we'll come in and we'll bring it into phase 2, sometimes in conjunction with NIH, sometimes on our own, phase 3. If it is succeeding, advance research and development, begin to ramp up the manufacturing, figuring out how those processes are going to work, get the regulatory components together to be able to help that company present to, to FDA to get approval and begin to carry through to procurement if it's something that we need. And then we also have the strategic national stockpile in ASPR. So we will then warehouse and store these countermeasures so the American people have them moving forward. Not everything needs to go into the SNS, but what this does is there isn't often a market for these countermeasures that we only need every now and again, hopefully. And what BARDA does is make sure that we continue to have access to this technology, access to them, and then the stockpile hangs on to them for use when we may need them. But companies don't have a lot of incentive to do this for a once-in-a-lifetime event, because you never know when that once-in-a-lifetime event is going to happen. So BARDA funds and incentivizes them to get into this business, to create these countermeasures, so we will have them and be prepared and hopefully never have to use them.
Thank you. Yeah, Rena, go ahead, please.
One of the other things that BARDA has launched this past year, I think, again, to their credit, is a sub effort called BARDA Ventures, which is essentially a mini venture capital group that is looking for technology that is platform based and has both pandemic responsivity applications to it, but also might have commercial applications for cancer vaccines or other types of therapeutics. And they are now seeding innovators who are interested in those type of technologies to get some public funding, but also some help in getting FDA approval and other resources. Again, this type of investment in entrepreneurial public finance is very well reasoned, and I think will again put us in good stead for the next pandemic.
Well, one can hope. Jen, let me turn to you. We've had a couple questions about a current court case around the Affordable Care Act's preventive services requirement. A district court judge in Texas has issued a preliminary ruling overturning parts of the ACA's preventive services requirement, which includes vaccines like the COVID vaccine. How do you see that case potentially affecting coverage of COVID vaccines?
It is a great question, and we should have said from earlier on this that we've been talking about the things that went in place for the emergency, huge amounts of federal purchasing of these countermeasures, including vaccines, public health emergency declaration. Congress passed a number of emergency measures that protected people, but all before that we had something else called the ACA, the Affordable Care Act, which already had protections in it. And one of the protections built or changes that the ACA era heralded was to provide a way that all Americans that have public or private insurance have access to a set of preventive measures. And they did that in a number of ways. One is, and these are going to be a lot of technical terms, so I'll try to just make it simple. One is something called the U.S. Preventive Services Task Force, which is what, for the average person's sake, what might say, okay, a certain kind of screening test is so important that your insurer shouldn't be allowed to charge you for it. You should just get it for free because we've deemed it so effective and important. That's one set. Then there's another group, ACIP, the Advisory Committee on Immunization Practices. And their job is to do that for immunizations, to say this immunization is so critical that you should get it for free. And if either of those committees make that determination, according to the ACA, you or I, if we have insurance, for the most part, cannot be charged for those. Just to go a little further before we get to the court case, so everyone has the background, that was already in place. And when COVID emerged, Congress went a little bit further and actually said in law, in one of the pieces of legislation that was passed to address the pandemic, codified, really called that out, said that, mentioned that provision, but did another thing, which said, currently under the ACA, once the ACIP says this immunization, you have to cover it, insurers have a year to do so. But they said this is so critical and we are so in such an emergency that for COVID, They only have 15 days. If the ACIP comes out and says, we recommend X, Y, or Z immunization for COVID, insurers have to cover it within 15 days. That's not going to change whether or not the government has purchased that vaccine for you, whether you there's a public health emergency or not. If there's a new booster next year that ACIP recommends, within 15 days, your insurer has to cover it for free for the most part. Now there's this court case that is challenging some aspects of the preventive services benefit of the ACA. So far, the court case that Larry mentioned has not called this part of the law into question. The ACIP determinations have been protected and are not in any way going away at this time. I think an ongoing question, though, is if the courts are going to chip away at this idea that we have preventive benefits that are so essential to our health, they should be free for those with insurance. But just the bottom line is, after saying all of that, vaccines are not affected as far as we know in this current moment, and they shouldn't be. But the court case, I think, just gives us all pause to think about, will there be a shift in this important change that happened with the ACA that protected people for preventive service access? Thanks.
Thanks. So we've also had a couple questions about a lot of questions about timing. So let me pick out a couple. So there were a couple questions about the flu. We've started to talk about the administration has started to talk about an annual COVID booster. There is a fall booster campaign in process now. That sounds very similar to how we approach the flu. Dawn, talk a little bit about how some of the similarities, some of the differences between how we might see COVID vaccination or COVID boosters in the future, and what we can learn from how the flu campaigns work.
Absolutely. So, we're lucky to have, the precedent established by this annual flu vaccine campaign to understand what works and what doesn't, what people respond to, what encourages them to go and get that vaccination. We've also learned a lot because we're able to get that, it's a platform technology. They're able to get whatever strain we think is likely to be the one that's going to give us a problem. In the winter, we're able to plug that in, all lessons that we're learning and, of course, applying to the COVID technology. We've got the mRNA technology in play, which is even easier to switch things and switch them in and out. In fact, just to note, between the time when FDA's advisory committee met in June and decided to do the BA4, BA5 as part of the bivalent to when the vaccines were available and rolling out to the American people was 70 days. It was super fast. So we are learning and able to apply some of what it means to stay ahead. It feels like there's a new variant around the corner that we're always trying to get ahead of, but we were able to do this so quickly with the BA4, BA5. It was remarkable. And one of the things the flu is able to do is to look ahead, look around the corner, look at other parts of the look at other hemispheres, figure out what's impacting them and apply that. So I imagine that will be similar moving forward. If we can get these next generation vaccines, though, if we can get vaccines that provide a little more durability, whether an annual booster will still be required will be up to whatever that technology is and how far ahead we get with that, our ability to invest in that technology. But we are learning that it's much simpler for people, and of course, much easier for people to think about one shot once a year. Going in and getting, we know a lot of people have been getting them at the same time, and we're encouraging that only go once and come out with twice the protection. And so we are trying to piggyback a little bit on folks' normal annual flu vaccine uptake and see if we can get some similar fall, updated vaccine uptake for the in the COVID space. But again, all a case of first impression. We would really like to get it down to an annual boost or maybe no boost at all, depending on what the technology is around the corner. But we're watching this very closely. Most important thing for us is that the American people have what they need to stay protected, and we'll continue to do that work.
And Dawn, let me stay with you. There are a number of other questions about timing and FDA approvals of antivirals versus EUAs, emergency use authorizations, which, as you said in the beginning, could affect coverage depending on what kind of coverage people have. I'm not going to ask you to predict when the FDA will do something. I know that's not in your control. But you did talk at the beginning about how the timing of commercialization might vary based on the type of countermeasure we're talking about. And that is potentially dependent on the FDA. Talk a little bit about how you see this timing playing out. How you're managing that process, particularly with respect to FDA approval.
Absolutely. So, we're very respectful of FDA's regulatory process and, encourage our colleagues at FDA to do what they need to do to keep America safe in this way, to make sure that our countermeasures are safe and effective. So we do, Larry, to your point, we do not intervene with their process. And the companies are actually responsible for putting that data together and delivering that data to the FDA. And so while we are all looking and hopeful that certain timelines will be met and we'll sort of aim for various places, it's really up to the companies to decide when they have the data they need in order to present it to the FDA. And then it will be up to our FDA colleagues to evaluate that data in the proper amount of time it takes for them to do that and to make their decisions. We are working with companies to try to understand what their interest is, how long we think and they think it'll take them to gather the necessary data, and continuing, to look with that. I mean, many of them, and Rena mentioned this early on, there has to be a business case for them to want to do this. And most of them want to do this. They are anxious to get to this next step, to be able to get out on the commercial market, and are very inclined to move forward. And so that's been an easy part, but still it does take the science, the data, all of those packages being put together and being presented. We had encouraged in thinking about timelines, vaccines, to begin that process, to start talking about this in a real way as we, round out the fall boost campaign. Are we talking, what does it mean, early to the middle of next year to begin to have the vaccines ready, depending on where we are in that process. The therapies, Eli Lilly's already gone in mid-August, which we were grateful for that. We've got the antivirals, which will go at their own time because they're under EUA and needing to get to the FDA. But let me just assure everybody, we do not intend to be in this business forever. We are very motivated and inclined to get this right, as are the manufacturers and the companies we're working with. So everyone is pushing to get there, and they're just different levers that have to be pressed in order to do it.
Great. Well, we're unfortunately coming to the near the end of our time. We have a lot more questions to out there that unfortunately we won't be able to get to. But wanted to ask each of you kind of what keeps you up at night right now in terms of our response to the pandemic, and in particular looking ahead to the end of government funding, potentially the end of the public health emergency. What is the thing you're worried about as we enter this period? And Jen, maybe I'll start with you.
Sure. Well, there's a lot I'm worried about. I work and come from public health, of course. So, but for this particular question, what I worry about the most is that we come to the end of these things that we're all talking about, and we anticipated would end, but we haven't figured out how to be prepared so that, let's say there is another variant that emerges in a year or two, and we're all of a sudden needing, a different pipeline of vaccines, which we now could get much faster, we know. But how are we going to pay for them? How are we going to ensure them market? And then we haven't really solved the problem for those who are uninsured and uninsured. Some of those pre-existing challenges are still there. So my biggest concern is that we're going to get hit again, and there won't be the sort of political support as well as public support to mount the kind of response that we have seen. So that could just have pretty serious ramifications.
And I might add, I mean, we haven't talked about some of the other aspects of the public health emergency, like the guarantee of continuous coverage in Medicaid, which has led to millions of people being continuously enrolled. That will end when the public health emergency ends. So, while the uninsured rate is at the lowest level ever right now due to that and the enhanced premium assistance under the Affordable Care Act, we could see backsliding at the end of the public health emergency. Rena, what keeps you up at night?
So that is what keeps me up at night is the emergency funding for ensuring delivery and access to all people altered. I think I have two other things that keep me up at night. The first is making sure that our surveillance for the next threat is as good as possible. The fact that we're still relying on wastewater in many counties and cities in America to assess where and not relying on other surveillance activities, I think is a worry, and one that I hope that that Congress will make some progress on. I think the second thing I'd like to see progress on is access. One of the lessons here is that the federal government underwrote technology and then guaranteed coverage and access to anyone who needed this technology. But it's not just in a pandemic that these two things happen, right? And that government has underwritten technology, and yet people still have difficulty getting access. And that's true for hepatitis C drugs, that's true for PrEP, for HIV, and it's true for other conditions where really the public health case for making sure that people get access at an affordable cost remains important.
Well, Dawn, I'll give you the last word to pick among the many things that I'm sure are keeping you up at night.
I was going to say, Larry, given my job, I don't sleep much at night. I have to be prepared for whatever comes next, whatever it is. And if it comes in sideways, like it probably will, how I respond to that. But in thinking about that, it's making sure that I have the flexibility to be able, I might not have the lever right at hand for that thing that we never anticipated, but do I have a lever or two that I can pull that gets me closer? An example of that, of course, was in the monkeypox response this summer. We happened to have a smallpox vaccine that we could use. We had stored it for another purpose, but we were able to make it available as quickly as possible, and we're pleased to do that. So making sure that I've got some flexibility in my response capabilities to be able to respond to whatever comes next and continue to scan the horizon for what that might be. So you can imagine in this current response, a variant that knocks out all of these countermeasures that we've talked about. What if our test didn't work? What if the vaccines didn't work? What if the therapies, and we've experienced the therapies coming offline, but how do we move quickly? And I think Jen said that. How do we make sure that we ramp up? So another thing that I've done in the work that I'm doing is making sure that all of these advances that we've been able to capture. I mean, what a unique moment we've been in when the whole country came together to be able to create these countermeasures, to make them available. We'll reflect on this time for years to come about what a unique moment it was for our country and how much we've learned. What I'm trying to do is capture the infrastructure we've built, kick it into the mortar of my organization so I have it and can use it moving forward to quickly pivot against whatever comes next. But there will be something next, and it will likely come in the living room window, and we just have to be prepared and ready to go and heads up to move out against it. But I do hope we're able to get next generation vaccines and therapies in place for COVID. I think that's going to be really, really important. And I do worry that we don't currently have a path to do that with our current annual budgets.
Well, Assistant Secretary Don O'Connell, Rena Conti, Jen Cates, thanks so much for joining us. It was a great discussion. And thanks to everyone in the audience as well, and for all of the terrific questions. And a reminder that this will be available later today on an archive basis as well. Thanks so much.